we had a patient come through and had received pembrolizumab or Keytruda for a long period of time, and it was approved by the health plan. When the referral came through on our end and our nurses reviewed that, it was not the correct treatment plan. And the patient had been on it for a long period of time, and they were asking for approval again. So reviewing that, and that the status of the cancer hadn't changed. In other words, it wasn't effective, but they still wanted to keep giving it. And so the cost right there, is a lot of cost that's, I don't want to say wasted, but it's not.
Oh, it is absolutely wasted.
I mean, it's the wrong treatment.
Hi, and welcome to the Captivating Health Insights podcast. Today we're talking about managing cancer spend and the human side of cancer. I'm excited to welcome our guests from INTERLINK, the Cancer Care for Life program. And today we have Kris Atkins and Ashley Urzendowski. Welcome, ladies.
Hi
Hello.
there. Thank you for having us.
Of course. So Kris, let's start with you. Would love to hear and let our audience hear about how you got into the industry and your background with the Cancer Care program.
I've been a nurse for way too many years, 40 years, but I've been doing cancer and transplant for 30 years.
Wow.
So I started working actually in a TPA. I had to sign 3 job descriptions. I did the utilization review and the case management for all of the transplant and cancer cases. And I was a nurse consultant to the entire TPA. So I helped write benefit plan language and work with the reinsurance filers. And so it was probably the best experience that you could ever have, and has led me down this path of 30 years of being able to do what I love.
Wow, a nurse for 30 years. So you did your time. You have so much patient experience, and now you get to use that in the cancer care program.
Right. I love being able to make an impact for the patients, but teaching a lot of nurses how to be able to help that. And there's a lot of people that understand benefit plan languages, and there's a lot of good nurses, but there's not a lot that know both sides. Mm-hmm. So being able to help the patients be able to navigate the managed care industry and to be able to understand the benefit plan language and help have nurses who know how to work that benefit plan language to be able to not only save the plan money, but also to save the patient money.
Gotcha. Ashley, what about you? How did you get here, and what is your background?
So I've been a nurse for a little under 15 years. My entire background has been oncology. So I started off in the hospital setting, med-surg oncology, and then kind of transitioned into more of the transplant world. I started in the Midwest and then moved to Arizona recently, about 10 years ago, and continued practicing there. I have done everything from transplant to infusion center to the clinic setting and so forth. So I just love being that liaison for patients, helping them understand where they're going, what the treatment plan looks like, and what to expect. So I came to INTERLINK not too long ago, a little over a year, and I'm just happy to be helping those patients in a different setting, a different light.
Gotcha. So kind of similar. You had that traditional nursing role, and now you're using that to help patients kind of virtually, digitally with cancer care.
Absolutely.
And for those of our audience that are not familiar with the Cancer Care for Life program, could you quickly explain just in a nutshell what you guys do and what your services provide to employer clients?
Yeah, we started building the program. I've been with the Cancer Care program for 11 years. I'm the primary architect of the program. And we built it to be able to help patients understand. And actually, INTERLINK is a 30-year transplant company. And so the reinsurance carriers were coming to INTERLINK and saying, but cancer is becoming our number one spend. Is there something you can do for cancer? So that's really why we built the program. It has evolved over the years. And We now are a full service program. Initially, we manage the patient while they're getting their care. But being nurses, it was terrible to feel like you were helping somebody get through their cancer. You know, when I first got into it 40 years ago, people died of cancer. And now so many people are having, it's becoming a chronic disease. They're living so much longer. So when they finish their treatment, they end up sitting in a heap of bills, in a pile of what do I do now, and they don't know what to do. So we built a survivorship program. So it's fully involved from prevention and early detection clear through survivorship, which brings it full circle back to prevention and early detection again. So we're able to, we actually have benefit plan language that we put into the plan docs so that it enables us to be able to help the patient get what they need, but it also saves the plan money. We're firm believers in the fact that we would never, ever risk quality to save a buck. We want to be able to, we feel like if we do the right thing by the patient, we'll end up doing the right thing by the plan.
Yeah, that's wonderful because, I mean, going through a cancer diagnosis and managing cancer for an employee has got to be, you know, one of the hardest things that they're ever going to do. So what an amazing service and solution to be able to support your employees through this hardest time in their life. And like you said, it's financially, it's emotionally, it's physically, it's mentally. So many things are taxing them.
You really nailed it. I like to say it. A cancer diagnosis is not like a hip replacement where you go in and you walk out the next day. You pay your bills and you're done. It is an ongoing diagnosis that affects every aspect of your life, every aspect, financially, emotionally, with your relationships, with friendships, your social life. It can be very draining, and people don't know where to turn. They don't know what to do. They don't know the resources that are out there for them. They don't know that resources exist. So it's really nice that we're able to fill those gaps where they may lack. Look for those potential barriers, have those conversations with the patient to really learn and understand what their need is. What is it that we can do to help them?
Yeah, that's wonderful.
So many times when a patient gets a cancer diagnosis, they don't even know what questions to ask. So if we're there up front, we can actually help them know what questions to ask their doctor. We want them to become informed consumers, essentially. We want them to be able to take part in their treatment journey, and they can only do that if they have all of the information they need. So we try and arm them with the right questions so they get the answers and can make their own decisions on what they want to do.
I actually had a patient, about a month ago, who she came to me and she's like, Ashley, I don't know what to do. I'm told I need to go into surgery. This is what I'm having. What do I expect? And I said, have you met with your surgeon to go? I'll meet with the surgeon the day before. So there's all these, how long does she need to be out of work for? How long is she going to have drains she's going to go home with? What's the care going to look like afterwards? So it's ways that we can put their mind at ease. They're still going to have that conversation with their surgeon, but take some of the worry off their plate. Giving them that information and guidance to get to that point, which is what I find extremely helpful for these patients.
Gotcha. So an advocate for them so they don't feel as alone in this process. That's,
Absolutely.
That's wonderful, and it's huge, I'm sure, for that employee or that member.
Yeah, Ashley was just telling me this morning she received an email from the wife of a patient that she had been helping. Go ahead and share.
So we had sent him, so his cancer was he's gone through every line of treatment and was just, his provider was saying, there's nothing more I can do for you. But he wanted that certainty. So we got him connected with a Center of Excellence for another opinion. Unfortunately, it was the same opinion, but it gave him peace of mind to be able to know that he's making the right decision because his wife was sitting there telling him, don't stop fighting, don't stop fighting. So being able to give him access to that, to give him a peace of mind, his wife a peace of mind. And I was just texting her this morning, and she was just saying how grateful she was, and we're in the process of helping with the reimbursement for their travel. So we're still in communication. She's doing well, but it's nice
huge.
to be able to help those people that need it and feel like they have nobody else, you know.
Yeah,
to turn
that's
to.
huge. Yeah, to have peace of mind for the rest of, their life, to know that they did all that they could versus
Exactly.
always wondering.
Yes.
That really can weigh on a person. So,
Or even the wife always wondering, or the
Right.
children always wondering,
right.
you know. So
That's true. Yeah, that's a wonderful story. Well, I'm so excited to get into this conversation today because cancer impacts so many people, so many employers. But before we jump into that, season 2 of our podcast, we're kind of diving into this question that I love. So the question is for each of you to answer. We'll start with you, Kris. Kris, if we really knew you, this is for our audience, what would we know? If we really knew you, what would we know about you, Kris?
It's funny because when I was in college, I had a nickname, and I was called Imelda Marcos. And for many of the young viewers, they're not even going to know who Imelda Marcos is. She was actually the first lady of the Philippines, but she is known for having over 1,000 pair of shoes. And I, to this day, have well over 100 pair of heels.
Love it.
And I love wearing my fancy shoes.
Love it. You have some fancy shoes on today. We can't see them in the camera, but we're going to get a picture, everybody. So you're going to get to see these shoes. They're amazing. So that's very cool. I had never heard of her, so I learned something. Imelda Marcos.
Marcos, yes.
Lovely. That's awesome. What about you, Ashley? If we really knew you, what would we know?
I think the biggest thing is I'm a busybody. I love to go. I love being around people. I love interacting with people, getting to know people. So I would say probably you'll never find me sitting at home doing nothing.
Always doing
I like to
something.
be out and about. Yeah.
Well, that's awesome. Well, that's great for your role because you interact with a lot of people every day and helping them.
And
through
she
their
is
cancer
amazing,
journey.
amazing at her role. Yeah, she does a
awesome.
great job.
That's
I
awesome.
do it for the patients. That's most important.
Well, it's awesome that you guys are, you're out of that kind of direct care environment, but you can still impact so many people today. So that's just wonderful that there's, different options out there.
I feel even differently than I could at the bedside. The bedside, the resources, you have great resources bedside for the treatment at that time. But you're not looking at the bigger picture oftentimes.
Oh, that's true.
You're treating what's right in front of you, hanging the next chemo bag or giving the next injection, and then they leave and they still have a whole worry, a plate full of worry.
Yeah, you're helping with their bills and
not
you're just helping them. That's a great point, that point in time. Now you get to help them holistically.
The big picture.
That's wonderful. That's awesome. Well, cancer spend is increased year over year. We're seeing it on, it's one of the highest cost drivers in an employer's plan. So in your guys' perspective, what is causing that increase and what should employers sort of be looking for in their claims data to understand what they should do about their cancer spend?
I think the biggest driver of cancer spend is the cost of drugs. And it's not just the cost of drugs, but it's the total cost. So when they're looking at cancer spend, you can see what comes on the claims form. But what you really need to understand is what it could have been. We pride ourselves in whatever cancer program a consultant chooses to use, there are certain things that they need to look for, and they need to make sure that they have a management company that is going to look at the total spend. Total spend meaning not just the cost of the drug, but the administration of the drug, where it's being given, what complications are going to happen from the drug. If they're getting a chemotherapy regimen, we try to make sure that they actually get the right supportive medications to keep them out of the hospital for long term. But the real big thing that we see a lot is site of care now.
Okay.
And that's really important to make sure that we get people in the right site of care.
Well, we recently, we had a patient come through and had received pembrolizumab or Keytruda for a long period of time, and it was approved by the health plan. When the referral came through on our end and our nurses reviewed that, it was not the correct treatment plan. And the patient had been on it for a long period of time, and they were asking for approval again. So reviewing that, and that the status of the cancer hadn't changed. In other words, it wasn't effective, but they still wanted to keep giving it. And so the cost right there, is a lot of cost that's, I don't want to say wasted, but it's not.
Oh, it is absolutely wasted.
I mean, it's the wrong treatment. And so that's what's great that we can do too is look at those things, review the benefit plan language, review NCCN guidelines, make sure the patient's getting the best possible care for the best possible outcome. And that's just one area that we touch on that also impacts cost.
Yeah, because Keytruda is one of those drugs I've seen on the commercials, and it's used for a lot of different things, right? So, and it's an expensive drug.
Yeah, Keytruda is FDA approved for 18 different diagnoses.
Wow.
So it can be given for most anything. And the issue is it's an immunomodulator. And so there's not a lot of side effects when you actually give the drug. There are long-term things that go on. But what they have found with the Keytruda is they're giving it in the doctor's offices. The cost of Keytruda in the doctor's office, we have seen it anywhere from $65,000 to $90,000 per drug.
Wow, because it's an IV?
It's IV.
Okay.
And you get it every 3 weeks.
Okay.
So it's ordered long term, at least a year, most often 2 to 3 years until they progress. So you get 17 cycles in a year.
Wow.
So you can look at $90,000 a piece.
Wow. That adds up.
1.7 million.
Right.
But if we can get plan language in that allows us to be able to move that site of care, we can get it in the home for less than $15,000.
Wow.
So we are going to save the plan $500,000 a year. That's just on one drug.
And
wow.
On top of that, think of what it's doing for the patient. They aren't going into the cancer care. Some people work from home. So to get up and go in and have their infusion that they're going to get for as long as they know, every 3 weeks, that can disrupt their work life balance.
Gosh, yeah.
And so
they have to find a ride to and from the clinic. They have to take PTO time. Their significant other has to take PTO time, and they lose all their PTO time.
So it's a
lose-lose. If they get it in the home, everything's taken care of.
It's less expensive and it's more comfortable. So why would we not, put it in the benefit plan language to have the site of care in the home if they want to do it that way?
Right.
It makes perfect sense.
Well, and it's a tough decision for a lot of employer groups, because when you're dealing with small and intermediate size employer groups, their employees are their family. And so physicians, oncologists, that's a big moneymaker for them.
Yeah.
I do not believe that oncologists are totally in it for the money. I've worked with enough oncologists over the past 30 years. I know that's not their driver, but their hospitals are forcing them to be able to make the money. So if they have to give it, then they're going to give it, and they want to be able to give it to make the revenue themselves.
That's their typical protocol that they're...
Absolutely. And they scare the patient. They say, oh, this is a really strong drug, and it's dangerous if you get it someplace other than here. And that, in fact, is not the truth. And if a consultant finds a cancer management program which actually uses a good case manager company, they're going to, number one, it's twofold. If they have the ability to do the themselves, they are able to stay on top of it. There are a lot of generalist companies out there and case management companies out there, and I give them all the props. They have to know everything. They have to know how to take care of somebody with a stroke, a total hip replacement. They have the full gamut of everything. Mm-hmm. But oncology, you've seen so many published articles recently where oncologists can't keep up with the changes.
Because there's just so much new research
Everything
coming
changes.
out all the time.
Yes. Mm-hmm. We get a weekly update with all the changes to the guidelines. And so it changes forever. And the generalist nurses can't keep up with all of that. Mm-hmm. But so they're approving things that don't need to be given, number one. Which is what happened in the example that she told about. It was approved by somebody else because somebody else had So they have to be able to give us the pre-treatment review in order to be able for us to make a difference. But then once it's done, you can't say, HR will say, the employee came into us and his doctor says that it has to be given in the office, so we just have to pay for it. So it takes a lot on the consultant. It puts a lot on the consultant to be able to speak to the HR saying, it's still going to be given by oncology certified nurses. It can actually be given in a separate office or clinic where we can still get it for those prices. Instead of $90,000, we can get it for $15,000. So it's a matter, it's going to take a lot of education for the consultants to educate the HR to say, this is necessary. Mm-hmm. And it's actually coming up with Aetna. They came out with new site of care policies.
Oh, really?
And their site of care policy now states that either one or two cycles can be given in the doctor's office, and after that, it has to be given outside the doctor's office.
Oh, okay.
So it's really going to change. The BUCAs are catching on. Mm-hmm. So we need to get the support in order to be able to save the plan all that money.
Mm-hmm. What's also nice too is if you do the you are with that patient from the get-go. So you can educate the patient before they go into their provider's office and say, hey, just so you know, you're going to get the one in the provider's office, the first one, and then the rest, guess what? They'll get to come to your house, and you don't have to leave to go to that next appointment. Mm-hmm. And just giving them education on the drug, the side effects, the potential side effects, and preparing them so that they know this is okay. This isn't something that is going to harm me. There's still a nurse that's going to be there. They still have any medication, backup medications if needed. Mm-hmm. And so it's really nice to be able to educate them before it gets to even the provider so that we can kind of prevent some of the misconceptions of it, if you will.
Yeah, that's super helpful. So would you say, what else, would you say anything else as far as when an employer is looking to manage their cancer spend? I mean, that was a great example with the side of care. Anything else you'd kind of call out for employers that have cancer spend or kind of trying to figure out how to tackle that in their plan?
Yeah, I think that it's really important to make sure that you have plan language that supports being able to manage it. Okay. So part of the issue with if you've got a BUCA network, the BUCA networks say you have to use all of our products, all of our programs, and you're not allowed to go outside. So we typically love it when a consultant will use a regional TPA rather than a BUCA and get a regional network. Because if they have a regional network, it captures everything that's in the region where the company is, where all the employees are, but get a BUCA wrap. Mm-hmm. So if they go outside of that network, then you still have access to the BUCA, but BUCA doesn't put the rules on it, and they still will allow us to get in there and be able to help and steer them to the right places. So our CEO worked with benefit plan language years ago, and he's been saying for 30 years, the benefit plan language is important. The benefit plan language is important. And I'm a true believer that he's a great entrepreneur and he's ahead of his time because it's just, you have to be able to know how to fix your benefit plan wording to be able to work for your employer.
Mm-hmm. That makes sense. And so focus on the benefit plan language, the side of care, and then, thinking about your TPA options. Or if you're thinking of making a change, do you maybe consider a regional network if that's possible for you in terms of how it would have impact managing your cancer spend? All right, Kris, can you talk a little bit about the difference between getting local treatment and maybe this misconception of people thinking that they have to get specialized treatment at the big name cancer centers? Is there a difference there, or what do you see there?
There's a big difference in how we look at cancer care versus transplant care. Transplant care, you really have to be at the center of excellence in order to be able to get there, get the expert surgeon's hands. But if you've got a really complex cancer, we may need that expert to be able to put together the treatment plan, but they don't have to give it there. We want the access to the experts, but then they can build the treatment plan and send them back home where they can get their care locally.
Gotcha.
And the way it's even better that way is because the local oncologists who may not be I call local oncologists the PCP of the oncology world. The local oncologist will see a brain tumor and then maybe a leukemia and then maybe a thyroid cancer and then a uterine cancer all in one day.
Wow.
They have no expertise. They're a generalist when it comes to oncology. So when they get these complex cancers, we send them to the COE, they develop the treatment plan, they send them back, and then if they give the treatment and they run into problems or the disease progresses, now they have the direct contact with that center of excellence. The physician can call the physician at the center of excellence and be able to say, okay, I did what you said, this is what's happening now, what do I do next? Then the local oncologist becomes the star. That's really what we want to be able to do. So we truly get access within the best place where they're safe within their local oncology, local community, with their support system near them.
That's awesome.
And with that being said, I had a patient that had a tumor right next to the brainstem. And so he went to his local oncologist and said, this is your treatment plan. And part of that was radiation. So he decided he wanted a second opinion, so we sent him to one of our COEs. They determined the same treatment plan. However, just a little modification. This center of excellence could deliver a different type of radiation that is more targeted to the tumor that will help prevent less complications in the long run versus what his local oncologist could provide.
Okay.
So going back to the physician-to-physician communication, the patient stayed locally, received the chemotherapy, went to the COE, did the concurrent chemotherapy with radiation, and then went back to the local provider for all the follow-up care and additional testing and so forth. So that took the COE physician and the local provider communicating with one another. And that's things that we help facilitate. Make sure there's no gaps in there and help get them the care that they need for the best possible outcome. So by him getting this targeted radiation, this proton beam radiation, we can't predict what his complications would have been, but what they could have been. Neurological deficit, motor skill deficit, so forth, had he had this other.
Wow.
So it's really amazing to see different teams work together, but what's even more amazing is that the patient not only got the correct treatment that they needed, but is able to continue locally, doesn't have to take more time off work than needed, doesn't have to travel, leave their kids at home with the spouse while they go, and yet they have physicians communicating. So it's
That's
just
wonderful.
really...
Yeah, the best of both worlds. You're getting that
yeah.
world-class expert opinion, but delivered locally for the most part. And I think, too, something I didn't understand is that in oncology, physicians work together a lot more, whereas you don't see that in other areas of medicine, like orthopedics or whatever. It's like, this is my lane. Like, I'm not looking for any other expert opinions. But oncology, it's so complex that they really love to work together because we need to, for the best care for the patient.
Absolutely.
Well, and the other aspect of looking at that is we're not just looking at the short term today. We're looking at, okay, if he would have gotten that radiation at home, the broad radiation, what would his return to work time been?
Oh, yeah.
So, when you're talking self-funded employer group, you're talking long-term with that employee. We want to minimize their complications, minimize their brain deficit from the radiation therapy. So that proton beam therapy, which is the specialized therapy, may have cost a little more, but you're going to save that in the return to work for your patient coming back. So you can't just look at a claim form to see how effective your cancer management program is. You've got to be able to look at the big picture.
Yeah.
And it goes back to putting the patient first for the best possible outcome. And that's what we focus. That's extremely important.
Yeah, and it makes complete sense because when you're doing the best for the patient, those other things are going to fall in place with return to work and productivity and mental health and all of those things.
Absolutely.
So from the employee perspective, Ashley, help us understand, what does that look like and what are the really big barriers that you all are helping support for these employees going through cancer?
Yeah. Cancer is so complex, like we've already said, and it affects all aspects of their life. And when we get a new referral and I reach out to this employee for the first time, I really want to know their whole lifestyle. I want to know what it is, what their daily routine looks like. I want to know what they're doing on the weekends. I want to know what their kids are involved in. I want to know how many kids they have, what they like to do, because this all plays a very vital role in what their treatment plan, how it's going to affect them. And if we can look at those potential barriers that the employee isn't even looking at that, they're just shocked they have a cancer diagnosis. Right. If we can help get them those resources that they need, we're helping in so much more than just treating the cancer. Body imaging. You have women that go in for mastectomies and they lose their hair. This is very important to women. This is part of their identity.
Right.
And a lot of people don't realize there are foundations out there that provide free wigs for women going through cancer. And we can give them those resources. And half the time I fill out the application form, So there's so many aspects that it affects. And one of the biggest things that I see is financial. If they have a spouse, that spouse continues to work, while they may need to, more than likely, take time off of work. But now they have kids' sports. We know these days sport costs so much. How are they going to afford that when the employee is having to take time off work and so forth and not bringing in that income? So there's a lot of ways that I'm constantly analyzing and looking deeper than the surface, deeper than the diagnosis, because in the end, those can be some of the most important. Yes, treating cancer is very important, but those can be some of the most important things to that patient. So I mean it's huge. One of the other things that I think is a big barrier is patients don't understand the benefit plan language. They don't understand the language that they're reading.
Right.
They don't understand what scan needs approved, what scan doesn't need approved. And those are things where we can step in and say, hey, looking at A, B, C, and D in the benefit plan language, you need approval for that scan. So why did they schedule you already? I had a patient that this happened to. It was actually a 1-year-old, so I was in communication with her mother, and she had an MRI scheduled for 2 days. And I was like, okay, well, so it's been approved already? And she's like, I didn't know we needed approval. They called her the day before saying that they needed approval. So I worked a lot on this one, trying to get in touch with the plan. We did. We had it approved that day. So the member was able to get her MRI the following day. It was for an MRI. The kicker is this MRI dictated whether she stayed on her current treatment.
Wow.
So if she didn't have that MRI, and let's say it was pushed out another week or two, she would have stayed on that current treatment. The MRI proved that her current treatment plan wasn't effective, so they needed to put her on a different treatment plan. So we could have sat for another 2 weeks with this member receiving the same drug that wasn't working.
Oh, wow.
So It's really important just to be that liaison and that advocate, and just, we have that full understanding. but really getting to know the patients and understanding what they don't know or what they need to know.
Yeah, because no one knows. They're not the average employee. 99.9% of them are not going to even understand that there is a plan doc.
Right.
We just don't understand this, right? We just get our health care and we have insurance and we go about our days. So that's so important.
A lot of times too, I get, I'm going to wait on hold forever to find that out. Let me take that off your plate. I'll figure it out for you. Or, well, I don't know. Do I need that? Well, did you check? No, but they don't know what they don't know.
Exactly.
So
they need an advocate during this time. Yeah. Really. That's the beauty of this. It's we're still putting the patient at the center, but we also have the plan in mind too, because it needs, it's not sustainable if we don't figure some of these things out.
Absolutely.
That's awesome. And speaking of the employer side, what metrics do you see employers tracking? I mean, obviously like total cost spend, go down cancer spend, but what should employers be looking for in terms of effectively measuring the success of their cancer management program?
Measuring the success of the program is tough because we talk about these cases, but there's not huge savings for every cancer case. If the doctors are doing the right thing, then the drugs are just expensive. And the patients, if you're a small employer group, you may have one cancer every 3 years. So you can't really tell it. Within captive resources, you're not just affecting that one employer group. The employer group is joining a risk pool. So with that risk pool, they're going to end up saving money through cancers that other employees have.
Right.
And you have a much better way of being able to look at metrics and to be able to tell how things are with a larger risk pool. So if you're within a captive, then you need to be able to look at those and then be able to look at your cancer management program actually should be able to report to you on what impact they've had on every case and what savings. Now, there may or may not be savings for every case, but the huge savings that they have on those big cases is going to make up for it. But you also have to look at the impact that we've made, not just for the patient, but for the plan also.
Wonderful. So moving on, what role does early intervention and engagement in the preventive side take?
That's huge because there is such a cost difference between treating a stage 1 disease than treating a stage 4 disease. So the earlier you can catch it, the better quality of life the patient's going to have, but it's an extremely better cost for the plan also. And along with early detection, you need to be able to make sure that the diagnosis is correct. Many companies out there, when you get a initial cancer diagnosis and they get a treatment plan, they look at it to see if that treatment plan is appropriate. We look at the top 10 most commonly misdiagnosed cancers, and we send that pathology out for a second opinion. We typically find 1 to 2 cancers every year that are completely misdiagnosed.
Really?
Absolutely.
Wow.
Lymphoma is the number 1 most commonly misdiagnosed cancers.
Okay.
So we actually had a patient that was going for transplant, came onto the plan, and we sent it out for path diagnostic COE, and turned out that the kid didn't even have Hodgkin's disease. That's why he never responded to the chemotherapy that the local doctor had given him was going for transplant. So he had a fungal infection. He just needed antifungal medications.
Oh my gosh.
Yet we had given him all this chemotherapy. And that was all before he came on board with us. And so then we found it. But early engagement is vital.
There's statistics out there. So for somebody on average, for somebody who is diagnosed at stage 4 is 4 times more cost than a stage 1 diagnostic.
Wow.
So the earlier you can be diagnosed, the better all around. Like you said, most importantly for patient outcomes, but even cost.
Even cost too, yeah, because now it's spread and it's more severe, and so it's going to be more, more
and
costly.
even kidney cancer, stage 1, just a survival rate alone is 93% if caught at stage 1. At stage 4, 13% survival rate.
Wow, it's a huge difference.
So the screenings the yearly screenings and the early detection plays a big role in all aspects of care. And then this one's kind of crazy too. So somebody diagnosed with hormone receptor negative stage 1 breast cancer, yearly average cost at stage 1 is $40,000. If diagnosed at stage 4, it's $110,000.
Wow.
So it just kind of puts those numbers, just put it into perspective for you, and just kind of the screenings that we have available and the preventative measures that you can take is vital.
And that's a part of the program too, is since you guys do the whole spectrum, it's also okay for this population doing a health risk assessment, getting your screenings, what are you at risk for, and what can we catch early, if anything.
Right. We have a prevention and early detection program where we do have the health risk assessment. It's an app on your phone. It takes you 10 minutes to complete, but it tells you whether you're at high risk. And if you're at high risk, then we partner with Myriad Genetics, and you can get in and get genetic testing done. And if that's positive, then you can get genetic counseling. So that's just vitally important. So we had a patient that I got a call from one of my nurses, a triage nurse, day before yesterday, and said, we've got a patient who doesn't have breast cancer, but she came back BRCA positive.
Okay.
Well, BRCA positive means she's at high risk for cancer.
Okay.
And she said, can we open her case even if she doesn't have cancer? And I said, absolutely, because there are several surgeries that she needs to have done to put off her cancer risk.
Oh, really? Even though she doesn't have a diagnosis?
If you carry the gene that says you are going to get it, yes, it is medically indicated for you to have your ovaries removed and have mastectomies done so that you don't get breast cancer or ovarian cancer.
Wow, I didn't know that.
Yes. So there are things that can be done. So the early prevention is really necessary.
And you're asking about lifestyle factors and genetics if you do the Myriad Genetics test.
Yes,
so it's looking
absolutely.
at both of them, which
it's
is
looking
nice.
at both.
Yep.
And then the app itself will remind you every year to go get your screening done. So it really works well.
That's awesome.
Which I wish I had a patient, and I wish she had this, because before she came to us, she was diagnosed like 7 years ago with breast cancer, went through maintenance therapy, and then quit doing screening, lost track with her oncologist for about 4 years, and then had recurrent disease, and it had metastasized. So had she done those screenings and those after her treatment, might have caught it sooner.
Yeah. Oh, wow. Yeah, those are hard stories to hear, I'm sure, when you
That's
you
a part
guys
of our
see those.
survivorship program. That's really important.
Yeah.
Survivorship to me is three things. Number one, it's patient support. But number two, it's preventing other cancers. Because the highest risk for you getting a cancer is that you've already had another cancer.
Wow,
and
so you're even in more risk, even
just
if
because
you're in remission.
That's right. Just because you've had a cancer, it automatically puts you at a higher risk for another cancer.
Wow.
And then again, the scanitis. Scanitis is real. People really are afraid to get their scans because they think it might show something, so they ignore it and they just don't do it.
So scanitis is just, I'm afraid, I don't even want to go see.
Yeah, I don't want to know. I don't want to know. I just pull the wool over my eyes.
Or I'll do it in 6 months.
Yeah.
Or then
putting
it's
it off.
another 6 months. And
So that's huge part of our survivorship program is we make sure people are getting that.
Wonderful. As we wrap up here, ladies, if there are any employers listening out there that are overwhelmed with managing their cancer spend, what is the first practical step that you would tell them to take?
I think the first step is to get a cancer management program, number one, but to educate your people. Educate your employees on how important prevention and early detection is, and make sure that you have great benefit plan design that will allow your partners to be able to help save your money, but to be able to increase the quality of life of your employees and to be able to save the plan money. You know, if they save money on their health plan, then they have more money on hand to be able to give raises to their employees.
Right.
You never know what can happen. But so it's a win-win for everyone.
All right, anything else you want to share as we close out today with our episode?
I think it's important to know that when cancer care starts early and is guided by the right tests and the right specialists, you not only save lives, but you also save money by avoiding costly mishaps.
Yeah, I love that. It's all about the patient and what's best for them, but also being a good steward of the health plan too. Well, thank you, ladies, for being here today. I'm so excited to have this conversation and help more employers know about the Cancer Care for Life solution and just how they can help their employees. So thanks so much for being here today.
It's been our pleasure. We appreciate the opportunity.
Yes, thank you very much.
Thank you, guys.